Welcome to our newest episode of the Lebanese Physicians Podcast. Today we will be discussing the topic of the Tahaddi Association, which is an association that serves one of the poor suburbs of Beirut, in the south side of Beirut. And today our guests are Dr. Dany Daham, who is the medical director of the Tahaddi Association. He will be telling us more about it today. He's a family medicine physician who's been at the association for a good number of years and has served this community for many years now, and also helps train family medicine residents at the American University of Beirut who come over and train with him at the association. And our next guest is Dr. MohammadAli Jardali, who makes his third appearance today on the episode. He is currently a chief resident in the family medicine residency program at the American University of Beirut Medical Center, and currently will be finishing very soon, and hopefully will be starting his career as a family medicine physician. So thank you both for joining us today.
Thank you for having me.
So thank you again for having me, Khalil, and thank you, Dany, for joining us today. I guess just to set the floor for the listeners, can you tell us why you went into family medicine to begin with?
It was a childhood dream, as usual. I was very much impressed by a GP that I was in contact with. He was part of the family during my childhood. And I was amazed by all the people he could see and the relief just by talking to people, them about things, sometimes that they're not sick, and sometimes by helping them getting services that are directly related to medicine. And he worked in a rural setting, so it was very picturesque for me. And then I got into medicine, and you get sucked up by all the neuroanatomy stuff and all these things.
And Dany, so can you tell us a bit? I know you ended up at the Tahaddi Association afterwards. We'll talk more about it in a bit, but can you tell us more about what the association does, how it came to be, and who does it serve?
Well, Tahaddi Association was created by a French doctor, Dr. Agnès Sander, a Swiss teacher, Madame Catherine Murtada, at the start of the 2000s. So they discovered by chance this that down the sports city, and at first they started like coming with a backpack with medications, with some clothes to give away, some toys to give away, to teach a few things to the children. And very fast they rented a few rooms for a clinic, and also for all classes for kids who got left by the education system. And organically, it started growing towards having more centers and more people working within. So it now has an education center that teaches kids who got left out by the education center, gives them maybe 5 years of basis of math, of computer, of drama, of music, and also has our healthcare center, our medical center, which provides primary care, preventive care, and we also have a psychosocial center which provides relief, like food vouchers or any kinds of items that families may need, and as well as social support and psychological support through psychotherapy and group therapy, and also job provision. Like we have our sewing shop where ladies can come and sew face masks or blankets, many items that can be provided to the market. And of course, they get a job, which is very important in our setting.
So yeah, it sounds like the Tahaddi Association provides comprehensive care, and really you walk the walk and talk the talk, not only talk the talk in terms of providing holistic care for the patients. So I know this is something that's very tough to do in a country where the system is fragmented, such as Lebanon. So I commend you and everyone working at Tahaddi for being able to deliver all types of care, not just the medical part, but also the societal, economical, and psychosocial support to the population over there. But maybe you can tell the listeners a little bit more about the social issues of the population, the poverty rates, the education levels. I think the listeners would be interested to know about who the neighborhood is made up from.
So the neighborhood is made up of many different factions. We have the Lebanese, some of them who have legal papers, and many of them who don't have legal papers. Of course, this makes a difference of what services you can access, and well, it's very important. We also have the Syrian refugees started coming in 2013 maybe, and who now make maybe population. We also have a minor ethnic group, which is the Dom population. The Dom population are similar to the Gypsies in Europe or to the Roma population. And so they not only suffer of the poverty that everyone suffers of, but they also suffer of social exclusion that's typical for the Gypsies population everywhere. Now, the area there is basically what you can qualify or describe, as a slum. The houses are slum houses. It's an underserved population on all level, resources-wise, water-wise, electricity-wise. We have an issue of pests. We have issues of basic violence that exist in all slums. So that would be a really basic description of the area there.
Yeah, and then Dr. Daham. So how do you serve them over there? So basically, you have the clinic, right? And so do you provide them with free medical care, free medications? How do they do their labs and X-rays and stuff like that?
So the consultation in our medical center, the consultations are free, and we have about 40 to 50 essential medication present on site. Now, what I must say is the doctor works very closely with the social worker, because a big part of providing care there is actually getting the care to the patient, because you could sit with a patient, prescribe any medication that you want, any lab that you want, any radiology exam that you want, and he will not be able to do them many, many times. So what we do is actually going to the social worker, asking the patient every time, this is what we're going to do. This is the approximate cost. What can you do? What you can do? And we go to the social worker, and the social worker first networks him with the right center, because we have a psychological obstacle for the people there to go out and to get places, because many times they feel they will be misserved. And the second part is the subsidizing. Like many times we will provide either partial or total payment of the exam or of the treatment that we're requesting. So it goes very much hand in hand. And so in family medicine, one of the philosophical dimensions of family medicine is the social aspect. So you have to be aware of the social dimension of the patient that you're talking to. But when we're exercising or practicing in a normal setting, the social aspect is not very far apart between the patient and the doctor. But there, it's like huge how much difference there are. How much we don't know the resources of the patient. We don't know the priorities of the patients, because many times we would be, working on hyperlipidemia prevention, and the patient be worried about something very different. He doesn't care about that part. So the social dimension of the encounter is much, much, much bigger than anything I encountered any other place. So this is how it happens. Of course, with time, we netted with many centers that assist us in providing this help. We discover that the center is friendly to person with poverty. This specialist is friendly with persons with poverty, which help us refer more easily.
If I can share my own experience working at Tahaddi over the past 3 years, it's one of the few places in Lebanon where the physician is empowered to do social prescription. So what Dany was saying about the social worker working closely with the physician, the social worker actually has her own clinic, and there's actually two social workers, if I'm not mistaken, last time I was there. And for almost every single case, as a doctor, I would go and knock on the social worker's door and discuss the case with her, whether it is a case of domestic violence, whether I'm suspecting something of the sort. And even when it's a case of, let's say, short stature in a pediatric patient. So at the tertiary care center where I usually get trained, when we have a case of short stature in a pediatric patient, we run $1,000 workup. We do all the hormonal panel, the celiac workup, endoscopies. But over there at Tahaddi, we just assume first line that this is a case of malnourishment. So we connect with a social worker, and then she's able to provide them with nutritional support. And then we're able to reassess them in a month and 3 months and see if they're back on track and they're gaining a few centimeters. Then we know it's because of the poverty and lack of access to food. Same thing with, let's say, a patient with diabetes. A lot of the time we're discussing carb counting and a diet when the patient's only food access is ramen noodles because that's the only thing they can afford. And they'll only drink Pepsi Cola because it's cheaper than distilled water. So we're able to connect with a social worker to make an impact, direct impact on the patient's diet, which eventually will impact their health. So at Tahaddi, they really focus on going beyond the medical prescription and going into the social prescription. And I guess it ties into the philosophy that Dany was talking about the biopsychosocial model care. So it's really integrated into the practice.
Yeah, because I think to remember, and then you can correct me too if I'm wrong, but the population over there is very poor actually, and their income is even lower than the lowest threshold of income in Lebanon, right? And I think a large proportion of them are illiterate too, right? They have not had the chance to even go to school at the right time. So Tahaddi not only helps them from a medical standpoint, but also help them from a social standpoint in terms of even helping them find meaningful jobs and meaningful work by teaching them some other things that they can do.
Yeah, exactly. Illiteracy is a big problem, and jobs is a huge problem. The availability of jobs and the access to jobs, because you see what we discovered in Tahaddi through these 20 years is how much the social aspect of care is important. And we learned that progressively, part of it theoretically, but a big part of it organically, and many times voiced by the patients themselves, by people in focus groups, in person-to-person encounter, where many times they say, we want jobs, we want legality of existence. Actually, this would be a major intervention to help any other aspects. Jobs, legality, and education. It would help the health aspect of everything. So this is how Tahaddi progressively expanded its services towards helping people who, of course, in Lebanon, you can't get people nationalities, but at least you can get them better papers. Like instead of being totally without any papers, having some kind of pending papers that help them access to more services. Same with education. Instead of being dependent on an education system that's difficult to access in a certain way. I mean, we're talking about illiterate parents who have to teach their children science and math in French, and they can't even read. So we need more attention to the child. We need classes that have less than 50 or 40 students in them. We need more attention individually to each child. And we provide them with actual skills that can help them get to the job market and help them with their daily life, how to be more resilient, how to be more communicative in a way that can help you in the outer society that judges you based on criteria that are not always unbiased.
I think what Dany is talking about, I don't think the listeners are able to understand what it means not to have any documents. And I was very surprised the first time I went there to Tahaddi and had such an encounter with such a patient, because if you don't have any official document, then you don't exist. So in the economy, we talk about the parallel economy and the informal economy, but we're talking about people's lives, which the state doesn't establish. They're not connected to the state. The state completely ignores them. So if you don't have any official documents, you're not able to enroll into the school, because the first thing they ask you when you go to a school is an ID. So if you don't have an ID, you can't go to school. And if you get sick, you can't go to the hospital, because the first thing they ask you when you go to the hospital is to show any sort of identification. And then it's just a vicious cycle. So if you don't have any official paperwork, your children will also won't have any official paperwork, and they don't exist in the eyes of the system. It's a very cruel system, and it's a vicious cycle. And only a few places, such as Tahaddi, are able to provide them with a parallel economy, so to speak, and an informal education, an informal medical intervention. Because if they go to the formal economy, they don't exist. No one will look at them. It's very cruel. I always tell the students when we go there, it's only a 10-minute drive from AUB, but it feels like a drive back in time to a different place that doesn't exist on a map, and it doesn't exist. You're going to a very impoverished community. Khalil was asking about the poverty rates. We're not talking about poverty. We're talking about extreme poverty that you only see on TV, on the National Geographic. We're talking about less than zero income for a family of 10. This is an extremely marginalized community, and poverty doesn't discriminate. So maybe Dany will talk to us about how the patient population's changed over there, and what it's like to practice medicine with little to no resources, because the extreme level of poverty, I'm at loss of words to explain it to the listeners, what it's like to live there and to practice medicine in that community.
So Dany, if you could tell us about that, and also touch on maybe if you have some numbers on how Tahaddi has improved the situation of some of the people there, and maybe give us an example, an anonymous example of a patient whose life was changed due to Tahaddi.
Sure. Just to give a living example about how things are bad down there, as Muhammad was saying. In 2010, we started cooperating with the University of Beirut Medical Center, and this is how we met with Muhammad. UB Medical Center Family Medicine Department started sending residents and medical students there for training and for service. So it was always a shock, like it was a shock for me the first time I went there. So about the level of poverty, we had medical students, and a lady came urgently carrying her granddaughter because she had severe burns on her buttock. And when we asked how did this happen, she said that she sat on a heater. So the medical student was shocked and kind of scandalized. He said, "Why would this happen? Why weren't you watching her? Why was the heater on the ground? Why didn't you put it on the table?" And the lady was explaining. She was telling him repeatedly, "We have nothing at our house." And the medical student wouldn't understand. He would say, "Why didn't you put it on a table?" And the lady would say, "We have nothing at our house." So we went in a home visit to this house, and we all saw, including the medical student, that they literally had nothing, no furniture, nothing inside the room. They had the latrine inside the room, and they borrowed this heater so they can heat some food from the neighbors. And they had one disabled child and one other child with chronic kidney disease that they had to take twice weekly to a hemodialysis session, provided by by someone. So this is the level of deprivation. I mean, a house with nothing in it. So this is why it's hard to apply common advice and our common sense to this situation. You have to learn from their resources, from their experience, in order to be able to provide good services. Otherwise, you'd be just inflicting things on other people. And this is how we can actually provide services that touches the people. Touches people's lives in our neighborhood.
Come from a place of privilege, and it's very, very hard to. We always say we should put ourselves in the patient's shoes and walk a mile in their shoes. But in this case, they don't even have any shoes, and they come from a very different place than we come from. I guess my question to you is, how do you think our biases affect medical practice?
I would say it's mainly about priorities, difference in priorities, and also the kind of image that our box that we try to put the poor person in, quote unquote, poor person. So first, we have to accept that these people have different sets of priorities. Sometimes we have to negotiate things, like if a person comes with symptoms that are very suggestive of a myocardial infarction, we have to push towards him going to the ER and getting proper care, because they live in such a sense of urgency. It's hard for us to understand. Let me give an example. These are people, I mean, none of us, I presume, ever had to worry about getting to bed without a meal, or watching his child go to bed without a meal, or worrying about getting evicted the next day, or having his child fall from a 3-meter height and not having a hospital to go through. So they live in this chronic stress situation where they have to worry about these things, while we don't. So it's kind of confrontation between two sets of priorities. And sometimes we have to accept what they ask for, not when we're worried about an MI or an appendicitis, but many other situations where we can provide them what they actually want without them getting harmed, of course. Taking as an example, preventive medicine. Preventive medicine is very important, and we try to apply it as much as possible down there. But for them, they use a lot an Arabic proverb that says, عيشني اليوم وموتني بكرة. Let me live today, and I'll see how I'll die tomorrow. Like when you talk to them about prevention, it's kind of not a joke, but something beyond. It's like the same problems we had with COVID-19, actually. I mean, talking to them about COVID-19 or trying to enforce the precautions, sometimes they called it, it's your disease, like our disease, the doctors, not theirs. They have a different sense of priorities that we have to apply. Sorry, I forgot the basic question. What was it? It was about, sorry, Mohammed.
Our biases as doctors.
Yes. And the second bias is trying to put them in this, Hollywood movie of poor person and the savior that is us, where they are like very poor and nice, and they're very grateful at the end or something. We are both humans and doctors or providers or whatever, and themselves. And sometimes we can get into conflict. I want this. No, I can give you that. Sometimes they're happy. Sometimes they're sad. It's not like these movies that kind of stereotype the poor or put them in a place where they should behave in a certain way. Well, I can say after about 20 years of being down there that there is no stereotype. People are people. They're happy. They have their joys, their pleasures, and coming with the idea of I am a savior and you must behave as the savvy. Not only doesn't work, is also very bad.
Yeah, and I think I know what Muhammad Ali is also getting at. The other part of it is when you, even when you are in your own clinic outside of that area, let's say sometimes you get different patients coming into your clinic, and a lot of us sometimes inadvertently or in the back of our minds, you always have biases that you try. You say, I don't want them to affect me, but a lot of time you have biases that tend to affect you, and I think that's something all of us should be working on to try to treat everyone as equal and not have biases with the patients. So Dany, do you have any like numbers? I know you may not have all these numbers, but do you have any numbers of like how many people the clinic has served and how many people Tahaddi has helped in this neighborhood?
Yeah, we have an active population, like patients we've seen in the last 1 year of about between 2,000 2,500. They belong to about 1,000 family, and we see between 400 and 500 consultation per month. We provide primary care services, family planning, vaccination, all free. We also provide psychotherapy in groups or in personal psychotherapy. I think, yeah, that's the basic thing as a health center.
And one more question I have. So how do you get your funding at this point? How do you get most of the funding for the association?
Well, we get our funding from many entities. We have small funders who provide assistance for specific services, mainly social services. And we have the operational funders like the Swiss Embassy, Monaco, Principauté de Monaco. And we also currently we are being funded by the UNICEF. So we have all these funders.
I just wanted to ask you how the economic crisis and the COVID epidemic affected your practice. I know we touched a little bit on it about how it's the doctor's disease and not their disease. I know there's a big disparity between, or a dissociation between the patient's agenda and the doctor's agenda. But how are you able to operate in the past year?
It's been terrible. It's been, I mean, we spent lots of energy to apply the safety measures for COVID-19, to convince people to apply them mainly. It's been the most conflictual time in Tahaddi's history between patients and us, because different set of priority. But we tried as much as possible, and we have succeeded, I would say, maybe 75% to apply these things. But many patients are not really convinced. They kind of do it just to make you feel happy, but they don't feel the urge, because COVID-19 is not a disease that kills people on the street, and it's not that terrible, thankfully. But at the same time, it's not, this is why it's not convincing to this population. I mean, they don't see it. They see it on TV, and it becomes a conspiracy theory. So it has limited a lot how we deliver services, but we got around it. We developed to our clinic, and it helped us a lot. We developed a system to send people to get their PCR, to facilitate to them, sometimes to pay for it. And recently we've helped, because COVID-19 vaccination registration is digital. So many people there are illiterate. So we're helping them register for the vaccination, and they're applying in numbers that surprised us really. So yeah, it was a big fight, the COVID-19 thing. Now, the economic crisis, you'd think that someone who's already in a very dire situation would not be affected, but no, it has affected much more people. So more people are asking for social assistance, for medical social assistance, and more people are being helped. Before that time, we would help sometimes people with 25% of their bill, 50% of their bill, because we knew that they can provide the rest. But now it's 100% on many levels, and it puts more pressure on our funding to distribute, and people are getting more demanding because they're in distress. They're asking for help, and the problem is we cannot help all the population that lives in this area. So it's tough times. More people are providing help, but still more people are needing help, which makes it more difficult.
Right, and this is an example, I think, of whenever there's an economic crisis in any country, it tends to affect the poor and middle class tend to be affected to much greater degree than the rich, and I think this is happening in Lebanon too. They were poor, and they even are now affected even more with that. And I think you guys have done a good job, I guess, convincing them about the importance of getting vaccinated for COVID-19, which means probably they're starting to believe that it's a disease that's affecting them. Otherwise, why would they want to jump in huge numbers to get vaccinated?
Yeah, with time, with the latest surge, they saw many persons die in the neighborhood because of COVID-19. So this was the point where it started to become more convincing, especially for elderly and people with other diseases. We did a survey to see how we can target our messages towards vaccination. And we had a percentage of the population that's higher than the national percentage who wants to be vaccinated. What they really needed is just help to fill these forms on Google Form or whatever, because it's computerized, and for them it's very difficult.
Great. So I guess this would be a good transition for us to ask you, what's the best way to help from inside Lebanon and outside, and maybe how people can donate directly to the Tahaddi Association?
Sure. Can I send, there is a gogetfunding.com link. Can I send it later, or?
Yes, for sure. You'll send it to us, and I think we'll put it on the site once we release the podcast. Exactly. Yeah, thank you, Dany, Dr. Daham, and thank you, Dr. Jardali, for being on this podcast. I hope people have learned about what the Tahaddi Association does and about actually some of the poverty levels that exist in some of the suburbs of Beirut. I think we tend to live far away from these areas, but all of us need to be immersed in this and try to help out this population of patients and people. Thank you very much.
Thank you, Khalil. Thank
Pleasure.
you, Muhammad, for having me. Hope I haven't been too boring. And
No, it was a very engaging conversation, I think.
Thank you.